Pediatrics, the Palliative Care chapter, and hosted by Pain Relief and Palliative Care Society, Hyderabad. Today's topic is implementing palliative care in different settings, hospitals, palliative care centers, in corporate hospitals, and how to form collaborations. So without further ado, I will hand over to our very expert, experienced speaker, Dr. Marianne McAdam, to share with us her experiences in setting up palliative care. Over to you, madam.
Thank you very, very much. Good afternoon, everybody. It's the last session. So I think now that you have all the knowledge that what you can do in pediatric palliative care, we just thought that the last session should be just giving you some of the experiences that we have shared. I mean, that we have experienced over the years. Not to say that you should follow anything of what we are saying. It's our experiences. And if it helps you, it's well and good. But probably you have to find your own way, and therefore these are the three of us will just be sharing some of the experiences. So reminding you all again, these three slides, you have seen it, I'm sure, many times. The definition of active and total approach to care. So as I'll be telling you a little further, as a radiation oncologist, we didn't think of that active and total approach, looking at physical, emotional, social, spiritual, quality of life. Probably, in my experience, we looked at this little sweet girl, as you can see in this picture, as the person with a cancer. So, what was the cancer? What was the stage of the cancer? What kind of treatment can I do for her? And will I be able to cure her or not? But then when I moved as a radiation oncologist into palliative care, I started looking at that active and total approach and looking at the various elements and looking at her quality of life and the family around her, their quality of life. Okay. So again, you've seen this slide just to remember, think of that little girl and think of patients of yours who you are also probably treating in your pediatric practice in the hospital or in the clinic, and think about if you are faced with someone like her and her father, and the disease was life limiting, whether you would be able to accept for yourself and also for them that living and dying is the same. I mean, it's all part of the same process. And therefore, we do not want to hasten that little girl's death, but we don't want to postpone it either. So, again, offering that support system, looking at the quality of life, looking at supporting that little girl and her family, and to see how we can do it best. So, with the team approach, and of course, as early in the trajectory of the illness as possible. Okay, so as I said, I wanted to just give you an understanding of my journey, and probably if it inspires you to maybe take up even 5% or 10% of what I did. It was a long time ago, and therefore things have changed a lot. I hope it will help you in setting up pediatric palliative care for wherever it is that you work. So I was a radiation oncologist, and we saw many of those advanced cancer patients. And being the pediatric radiation oncologist, again, it was not that easy that when you saw all these children with life limiting conditions, how can you help them? So as I said earlier, in the beginning, when I first joined Tata Hospital, it was the cancer and how can I cure this child? But when you realize that there's a lot more into caring for these children than just the disease process, you realize that there's so much more that you can do. And being an oncologist, for me at least, it helped a lot because I could argue with my own colleagues, with the pediatric oncologist, with the radiation or the chemotherapist, or even the surgeon, that see, I know I've done this in the past, and I have the experience to say that the burden of this treatment is far outweighing the benefit of the treatment. So if you keep looking at burden and toxicity, there is a time when you realize that the treatment is far more toxic than the benefit, and trying to convince first yourself, then your colleagues, and then the family that maybe to start thinking of stopping the treatment is a better option. So if many of you take up this option of setting up a pediatric palliative care clinic along with what you're doing either in the hospital or in the outpatient, just keep that in mind that yes, treatments are there. You have all the knowledge of the treatments. Important is where do you put a stop to that. Important is where do you think of the toxicities and the benefits. And more important than that is to have those like-minded people along the way. It doesn't have to be a journey all of your own. You need to have your colleagues around with you. You need to have those discussions. We have joint clinics for every child, for every adult also, but also for every child. So it's not my decision. It's not the pediatric oncologist decision. There are at least 10 people sitting around that table where every patient is discussed. And therefore, everybody's point of view is taken into account. And probably the palliative care person would be, talking the loudest about the toxicities, because we have faced the toxicities maybe more than the oncologist who's doing cure. And that's how we have, over the years, been able to reduce the kind of treatment done for these oncology patients right along the way. And that is, I think, where the team approach is really, really, really important. And of course, when they had to go back to their hometown, because most of the patients who come to Tata Hospital come from different towns and villages, then can we help them from where they come from? Can we find a pediatrician or a GP or even a barefoot doctor who's willing to listen to what we want to, help them to take care of the patient themselves? And I think that is really the most important thing. It's not, again, like I said earlier, it's not just the disease and the cancer and the child, but it is also the other aspects of the suffering of that child and the family. Put it all together and look at it as a whole. So what we are talking about is, as you already have heard, is about holistic care. So right in the beginning, now what is for me beginning was somewhere around 2001, when I decided to set up the pediatric palliative care. We set up the adult in 1996. So like I said, it's a long time since I got into this. My experiences may not be the same as yours. I just hope something will be helpful to you. So as a radiation oncologist, I had to do both, and therefore I was able to set up this OPD only on half day. And for pediatric, it was only on the Tuesday and the Thursday. And we realized very early along the way that just being an oncologist is not enough. So as a radiation oncologist, honestly, I'm saying I never had so much contact with the nutritionist or the physiotherapist or the occupational therapist or even the medical social work department. But when you realize a host of difficulties, and you've seen this in the last 12 weeks, the host of difficulties that the children and family are facing, you realize that besides these people, there are so many who need help. Okay, now from a government hospital that I'm from, where's the money? First thing any administration will tell you, sorry, there's no money. So in the beginning, there was absolutely no money. That is why I was a radiation oncologist and a palliative care physician. Not that I was getting any extra remuneration. I had to carve out for myself from my radiation duties these OPDs in the afternoon, and I still had to do my full radiation work as well. So I realized that, see, okay, if the administration is not going to give us any money, it's going to take them years to find that money. I got to find other other people who are going to help me out. So in the hospital at that point of time, there were these two voluntary organizations who are working towards helping financially and for counseling. We Care and and the Cancer Patient Aid Association, already working in the hospital to counsel patients and give some little bit of financial aid. So very soon I realized that, okay, these are two now real allies who I could approach, and they were very understanding. They listened immediately. We set up training for those volunteers so that they could become our counselors, knowing full well that to wait for a hospital counselor might take 5 years. Actually, it took even longer than that. But we had these volunteers. We trained them. They became trained counselors. So it's not as if they were just saying any or doing anything, but they were trained and they were competent, and therefore they became the counselors. They helped a lot in financial aid. A hospital gave us all the medicines that we needed. The nursing department, where they were deputed for us to help us with the nursing of these patients. We could always send our patients to social worker, and they would bend backwards to try and help these families with whatever financial aid they could. The Global Cancer Concern India came along somewhere, I think in the year 1999, and helped us to set up the home care, because adults and children both would be much happier if we could visit them. Yes, home care is expensive if you try to set it up. If you if you count the cost per patient per visit, it's much more than the patient coming to you. But here we're talking about sick children, and therefore setting up a home care service along with the adult, which is what we were doing all this time. Now we have a dedicated pediatric service. But if you can set it up, they came to us and they funded us for almost 10 years. And then after that came Empathy Foundation, who gave us another 2 home care. So we actually landed up having 4 home care teams, and all from outside, so that we could cover the whole city of Mumbai for most of our patients. And slowly came other organizations who joined us, like Palcare and Romila Palliative Care, who did home care, and therefore we were able to share the burden. As you can understand, Mumbai is a huge city, and there are so many places that it takes a long time even to travel from patient A to patient B. But by collaborating with the other home care teams, by having going in one direction on one day where you can cover 7 patients all in one direction, we found that we were able to do quite a good home care service. And now, of course, we have a dedicated home care service for the pediatrics. Very early along the way, I realized that, okay, yes, WeCare and CPA are doing great job, but we need to have our own volunteers. So we started advertising. We started having World Hospice Palliative Care Day programs so that people would get attracted to what is palliative care. And even now, we have almost 35 volunteers who are individually trained volunteers, so that they don't get paid anything. So rather than going for their kitty parties or whatever else they would be doing, they come and volunteer themselves once a week or twice a week. So for pediatric, there are on Tuesday and Thursday, we have at least 4 volunteers who come in, and I'll be telling the experience of our other hospitals as well. So the individual volunteers are really very important. So an example, for instance, of this child, you can see he has physical symptoms, social, psychological, and spiritual. I won't go into the detail, but just to touch on the fact that his mom had passed away, and he felt that he was the adult in the family, and therefore he couldn't communicate with us, because he felt, if I cried and if I let down my emotions, and I am actually letting down my younger sister. But it took one of the individual volunteers actually, who was able to reach out to him. And now, as you can see, the nurse and the social worker, he's not being held down, he's not being tied or anything like that. He's just cooperating with the dressing. And you can also see the wound is not a very pleasant wound. Okay, so in the hospital, as I said, all the oncologists, the pediatricians, very soon we got into other projects. So we got the HIV people on board. We have as I told you earlier, physiotherapists, occupational therapists, nutritionists, speech, swallowing, all those NGOs. Outside, many community organizations, some religious organizations, social work organizations, all coming together to provide this holistic care, which you have already heard about. Okay, so these are also some of the other organizations who came across slowly, because we started a HIV center. So we came in touch with the Maharashtra district HIV, the Maharashtra state HIV. We soon got together all the palliative care people in the country and approached the center, where the palliative care policy was written for us. We have so many other organizations, as I've given you a list. So for me, the experience was, if I don't have money in the hospital as a government organization, there are many people outside who are interested in helping out. They just need to find that particular space for themselves. And as you can see a list here, there are so many organizations who have come forward to help us over the years. Associations also, Indian Association of Palliative Care, Catholic Hospitals, Christian Medical Association. There are so many of associations, both Indian and international. And just one word, I'll talk about how I got involved in the International Children's Palliative Care Network, which was started basically by people in Africa, because they also felt that they needed to have a forum where they could look at difficulties in Africa, South America, in Asia, Thailand, Malaysia, etc., and we all got together and we shared so many ideas and so many research projects, everything together. And thanks to that organization, the UK DFID, that is Development Fund Organization, came to us and approached us to and gave us some money to set up basically in Sion Hospital, because it was a center of excellence for HIV for children. And with that, we then set up something in the rural area and then in the semi-urban area. So these are just some photographs and some of the things which were done. So this was a very tribal area where we set up for the first time this children's palliative care. And that is also something which, if at all it works for you, because of the pediatric setup, we were able to get into the adult setup, I think, in a much better way. So it really worked very nicely in this tribal village. And with that, we were able to get to the Maharashtra government and actually do a lot of work with the Maharashtra government. This is the second, this is the HIV center, and as you can see, the kids are so happy. They don't look like patients at all, do they? They look as if they're having the time of their lives, as are these, which is one of the one of the centers for HIV, which was set up by an organization called Happy Feet. So you can just see that there is a lot of happiness which can be brought not only in the hospital but by collaborating with many others. So we've had other projects. We've had the, as I told you, Balkrishna Tires. They gave us some money where we set up these small little centers in Aurangabad, in Goa, and we're hoping to set up something in Jaipur. And the CIPLA organization, where again I'll be just showing you a little bit about what we do. So in this CIPLA organization, we've got right now 3 hospitals going, and the 4th is just coming. So in Rajiv Gandhi, we've already had more than 800 children registered. In Nair also, which started 2 years down the line, there are 300 children, and the neonatal has started now. It's about a year, and that is also doing very well. We are just now in talks with the Borivali place for hematology, so thalassemia patients, all those kind of patients we will be taking. One small example, because I know I'm just beginning to run out of time. One small example of this child who was, for instance, again collaboration, picked up in Kalwa, which is the government, through the state organization. So you can see this child. He's bed bound. He has brain damage. When he came to us, he was still having those convulsions, lots of contractures, bed sores, social problems. And therefore, because we had that problem, because of all the problems that he had, we were able to do whatever best we could. But then we could contact the Vadia Hospital, which again is a center of excellence for pediatrics, and we were able to do a lot of things which we were not able to do. So these are some of the things that we are able to do with reaching out. The organizations give you money, or we have lots of people. We keep contacting people about, can you help us? Can you help us? And there are so many people who give us help for ration, for medicine. Counseling, of course, is part and parcel of what we do. For rehabilitation, if it's not in the hospital, we send to Thana Municipal Hospital, which is outreach, and there they can get physiotherapy, they can get speech therapy. So it's all about collaboration. If you don't have it in your own hospital, find it somewhere close by. If you can't find it close by, refer the child to a higher hospital. If maybe you need money for that, you find the money for that. So it's all about just reaching out and reaching out. So if you're going to be very quiet and sit within your little sphere of your practice, I think you will not be able to go as far as if you reach out and if you persevere. I think the second part of all this is the perseverance. Okay. So with all this work that we've been doing, it's about, say, 15 years. We have been able to help so many. So 1,000 may look a very small number. But if you think that there is pediatric palliative care and you've helped each and every one of these children to live the best possible quality of life along with their families, help with the siblings, with education, women's empowerment, so many things. So we have done, and then, after in cancer, 1,000, but in other cancers, 5,000. We have so many other centers have started because we are able to give them help to start. We are able to give them training. We are able to do the policies. We have even been able to do lots and lots of training and some research as well. So I think these are just some very small experiences that I wanted to share with you. This is a wonderful organization in Chennai where I help them a lot, and I think if ever you all can visit Golden Butterflies, it's really great. You also know there's lots of training and research available online, offline. There are so many courses. You can just find one and take it to yourself, use it for yourself. So I'll just end my part of the talk by saying that, yes, wherever you're placed, you may not have the funds, you may not have the wherewithal, but there are many like-minded people like you. Reach out, join hands, and start something which works for you. Okay, so thank you for my part of the talk, and I look very much forward to listening to the others who are going to speak.
Thank you so much, Dr. Marianne. That was really inspiring. And, we all felt like, yes, we can also do it, because you gave us so many practical suggestions. And what you told us about holistic care, about collaborating, of going out and asking for help, and about the volunteers was very inspiring. Thank you very much. Now, I'd like to invite Dr. Gayatri Palad who is again very experienced in setting up pediatric palliative care fellowships and palliative programs. She's the Associate Professor of Pain and Palliative Medicine at MNJ Institute of Oncology. She has trained practically all the healthcare givers in the primary health centers in the state of Telangana. And she's also on the board of directors of the IAHPC. Ma'am, it's over to you, please.
Thank you very much, Dr. Savita. So just correction, I was in the board of director IHPC, not anymore. And also I'm a part of ICPCN where Dr. Marianne was the chair just in recent times. Thank you very much for the introduction. And just allow me to share the slides. While I'm doing that, just want to say, like, I'm just building upon what Dr. Marianne spoke about, a very personal story, evolution of pediatric palliative care, I would say, in India. I would say not only India, in this region, entire Southeast Asian region, I would say Marianne is one of the pioneers of pediatric palliative care. And the story just helps us to understand the struggle, but the determination, and also like how alone, one person alone, if you have the intention, you can do it, but it's not possible for one person alone to do it, how she created that network. And all of us, what we did was building upon what she did. So I'll start with that note. I'll just share some of the experience of my working in Hyderabad. But before that, I'll just, I thought I'll start with understanding this very basic concept. Like, we all agree that whenever we are working in a hospital, patients are the center of all care. And the care should be tailored to meet the individual needs of the patient, not patient meeting the needs of the health system. I think that's something very basic core of any health institution which we build. But somewhere, most of the time, it doesn't happen like that. But that's something we should remind ourselves. So when you talk about implementing palliative care of pediatrics in different settings, we have to understand the special needs of the children, because we are talking about children with life-limiting conditions. So what are their special needs? That's something we had to build upon. And let's understand the special needs are that they are the sick kids, like Dr. Marianne mentioned, very sick children, and they need care for rest of their life, 24 hours, 7 days a week. So this is the kind of care we are describing. So when we think about setting up of palliative care, we have to remember that these are the children we're dealing with. And they need continuum of care throughout their disease spectrum, from the day they make a diagnosis over a time, and wherever they move across different settings. Because it's not that only when they're in the hospital they get wonderful care, but when they go back to the home, they don't get anything. That doesn't help, because they need care throughout wherever they are moving. They are the children who are little grown-up children with restricted mobility. And very often, especially in pediatric palliative care, we have more than one caregiver. So not just a mother, father, extended family, like grandparents, aunt. Often we see them surrounded by many family members when the child is sick. So like we said, we have to, can you hear me, Vinila?
Yes, ma'am.
Yeah, we can hear you, Gati. We can hear.
Thank you.
Yes, madam. Yes, madam.
Yeah, thank you. So the child, the family, they should be seamlessly moving from their home to the hospital. It's a kind of cycle, goes on and on. When they're in the community, different kind of care setup they need. When in their hospital, they need different kind of. They are. So it should be care anywhere. Wherever they are, they should get care. And they should get care anytime. They should get care along the disease spectrum. Like initial days, it can just be outpatient. If you see the spectrum, hello?
Yes, ma'am. Please.
Yeah, if you see this disease spectrum from the day diagnosis till that, initial days, they may just get care in their outpatient service or in the hospice care, all settings possible in the initial day itself. And as the disease progresses, the extent of care which they need in the community becomes more. Of course, the hospital remains the same, but they need more and more community-based care as the disease progresses. But wherever they are and whenever they need it, they need care. Very strong recommendation by American Academy of Pediatrics. All hospitals and large healthcare institutions that provide care to children with life-threatening conditions and routinely provide end-of-life care should have dedicated interdisciplinary specialty pediatric palliative care team. So if they're talking about all healthcare institutions providing for children with life-limiting conditions, they should have a pediatric palliative care program. In the hospital, we can have various settings. We can have outpatient only. When you talk only, I'm just talking about palliative care mode of delivery. In the hospital, we can have that's the easiest way to start. Start just like how Dr. Marianne started, just the 2 days a week. She started with outpatient service only. Very soon, we may have to do certain procedures when they come on outpatient basis. So you can have the outpatient in combination with daycare facilities. Very soon, you'll be called to take care of patients in the wards. They'll say, hey, can you go to that female ward 2 or children ward? There's one child, bed number 4. Can you have a look at it? That we call it as inpatient hospital consultancy. So all of these first 3 type of services, you don't need a lot of staff. You just need core team, and then you move around and you're working on outpatient basis. As the program grows, this is based on our own experience, what we have seen. As the program grows, soon there'll be huge demand, and we'll feel the need that we must have our own inpatient facility, because the children, they need complex care needs. So you need to have our own trained staff to look after these children. And of course, more and more people are talking about intensive care, emergency and palliative care interface. They say in a outpatient or emergency service, any emergency service, if you look at it, maybe around 30 to 40% or sometimes more, the children, why they come to outpatient emergency service is because of some chronic condition and acute exacerbation. So ideal situation, you should have a palliative care team placed in emergency service also, so that they attend to this acute and chronic needs of the child. So there's more and more discussions around intensive care as well as emergency and the palliative care interface. Of course, these models should be supported by home-based and by hospice care. Another thing we have to determine, and we have to remember when you're setting up of a palliative care in your hospital, remember that, like I said, they always have more than one caregiver. Many hospitals, they restrict caregivers. They say only one person. But in this situation, we may have to find a way to allow the extended family members. There should be comfortable waiting areas, because they are very sick children and the family are exhausted. So, and they should have access to wheelchair and stretchers. What we have seen, years of experience of me and Dr. Marianne, I'm sure Dr. Marianne will agree, whenever we meet the management and we say we need to set up a palliative care, the priority is very low in the list of things they need. So they'll give you one corner space behind the building, one somewhere where we won't have an access to wheelchair. So we should not accept such a situation. We have to get a place where they can have access to wheelchair. Now, this is a picture of, I'm sharing a very remote palliative care center in one of the districts, and how they have good access to patient. Of course, in the rooms, because they may be spending days together in the hospital. So it'll be nice if they have a nice spacious room, very desirable, with natural light and large windows, so that they can look out. Otherwise they won't even know it's day or night, not just for the child, also for the family. And of course, they need special beds and the provision. Now, this is another thing we insist. This family should get a place to rest. This is one of our hospice space where if you can see, the mother is resting nicely. The family, because it's day and night, remember, 365 days, 24 hours. So they need to rest, and the hospice space. Remember that most of our families, they have their own toilet habits. And so we should be mindful of what is their habit. A family who spent all their life in the villages, and you give them some fancy Western toilet, sometimes they find it very difficult. So just be mindful of that when you're setting up a program. And again, access to wheelchair, going to the toilet. It will be very desirable to have some kind of outdoor area, where child-friendly pathway, where they can, child and families, they can go outside once the round's over, investigations over, some easy time they can spend outside the place where they spend all their treatment time. So nice recreational activity. Now, play, I think you must have had some discussions around play therapy and how it's so important, both formal and informal play therapy for a child undergoing this kind of chronic life, very distressing time they experience. And play is a means to express their distress and to ventilate their distress. So there must be a designated play area created for these kind of children. So of course, all children hospital, they usually have it, but this should be very well thought after. You need not have fancy place, but a safe place where they know that if I come here, it's no more of treatment. It is my safe place where I don't have to worry about my treatment. They leave this cannulas, injections in their ward. And I just 2-3 slides. I want to talk about some excellence. They talk about clinical excellence and safety and the recommendation, where they talk about how every hospital dealing with such children, we should have age-appropriate assessment tools. The whole idea is that when you use these tools, you identify distress, identify symptoms, and when you so that you anticipate symptoms like pain, and then when you use this age appropriate tool, you recognize those symptoms and make a care plan. So every hospital should have this in place, and a proper standardized format to recognize, to document these problems. Dr. Marian spoke about holistic care, where she spent considerable time describing how it's not just the physical part of it, so many other aspects of child's care. So a typical palliative care documentation consists of recording of all of these aspects. And this need not be a doctor doing it alone. Your team can do it. Each team member can have their own page where they can document what is needed in a standardized format. Yes, of course, if you are planning a palliative care program, it's time that you look around and find how are you going to get your opioid medications, because it becomes a very essential part of palliative care. You must have uninterrupted supply of opioids and adequate storage and dispensing system in place. So I think when we discuss maybe some point today, and if we can discuss around procuring opioid and how to go about it. And another standards they talk about, whenever we're planning a pediatric palliative care program, the team should be adequately trained. They should have sufficient expertise to address the physical, psychosocial, spiritual needs of the child and the family. Without that, you cannot provide care. Dr. Marian spoke about volunteers. Even the volunteers, they should have some basic training before they even touch the child, approach the child or the families. They should have some minimum training. So when you meet the administration or the management, definitely Dr. Marian said, money, where is the money? Often they'll ask about where is the source of money? And we should have a proper financial planning. And remember that when you're planning, it will be very difficult to explain, but 80 to 85% of our costing goes towards human resource. We don't have very high-end machines. Often it is a human resource which is required to run a pediatric palliative care program. So very difficult to make them understand, but that's something it's there. It should be featured in your planning. A child, like I said, child will be moving from one program to another. There will be transition. It should be anticipated, planned, and coordinated so that even the child goes home or to another program, there should be a proper handover and the child continues to get the care which you're giving. So there should be proper transition in place. Dr. Marian spoke about the partnership. So partnership with the local NGOs, faith groups, school, very important. And even the event of end-of-life care, linking with available funeral services. So Dr. Marian spoke about what's happening in Mumbai. So I'll just take next few slides to speak about my work in Telangana and Hyderabad. A kind of a different kind of a similar model actually, like how it all began. Like I said in the beginning, I work in a tertiary cancer hospital. I'm head of the pain and palliative care program, and we have a formal department of palliative medicine, which is a nodal center here for the training, clinical services, advocacy, everything. And we have a very unique pediatric palliative care program. Why it's unique, I'll just tell you, because we have a very specialized team of doctors, pediatric palliative care consultant, nurses, and social workers doing just pediatric palliative care. So we have adult program, separate team, for pediatric, separate team. And so in pediatric palliative care, we see around 40 to 50 children every day for palliative and supportive care. And almost all of them, they need, because they have children with cancer, very often they need opioids. We have various services which we provide, even 24-hour phone consult. So every child is designated one counselor, and that child knows that this is if I want to reach out, this is my counselor. And we have a very unique program. We call it a Say No to Pain. Every child in the ward is screened for pain. So our counselors and nurses, they go from bed to bed, and this is a process by which they also make friends, say hello to them, get to know them, and we screen them for pain. So we have this use the scale, and the children, they understand, because we ask them every day. So when the moment they see our scale, there comes a pain team, and they'll tell you today it is 3 out of 10 or 5 out of 10. So we screen, and when we see a child in higher degree of pain, immediately they're brought to the attention of the doctor concerned, and so we address pain early. And similarly, we have a very specialized procedural pain relief program, because many of these children undergo a lot of procedural pain, and so things like we routinely, all children undergoing intrathecal injections or bone marrow. The bone marrow, of course, they undergo anesthesia, but intrathecal, we apply EMLA cream so that they are pain-free and conscious sedation. So different services we provide within the hospital, like symptom management, end-of-life care, rehabilitation, psychosocial support, lot of nursing issues, and dealing with complex social issues. By doing this, like we see every child who's enrolled in pediatric oncology program, the palliative care team also get involved from the day one, starting with pain screening, and then saying hello to them, making friends with them. So what happens is there's very early integration, and in case the child develops progressive cancer, unfortunately, there's a smoother transition to palliative care. So it's not that suddenly this is over, now you go to another team. So the child and the family, they already know us. So pain is routinely screened, and all of these things leads to better treatment outcome. Many children, one of the reasons why children, they don't cure of cancer in our country is treatment abandonment. When you take care of their pain, they come back for treatment, what we have seen. So these are different ways how it affects the treatment outcome. A few years back, Dr. Ishaq is there, Dr. Ishaq and many other team members. So 4-5 years back, 2019, we started a very specialized non-cancer palliative care in Nilofer, which is again a very large tertiary children's hospital. And again, a separate team there we have, and we look at all the different non-cancer conditions, both in neonate and pediatrics. So different conditions which we see. And so all of these children, both in MNJ and Nilofer Hospital, once they are registered, we also look at how do we provide care of the child where they want to be. And all of these programs, even though they're running in government hospitals, we are supported by an NGO called Pain Relief and Palliative Care Society. So this NGO supports this program in MNJ and Nilofer, but also when the child moves out of these hospitals, they are supported in the community. So we have a very unique pediatric palliative care home care program. 3 vans every day go out in the city community and take care of children in the home setting. We have here Dr. Ishaq, who's one of who was till recent time, he was in our team, and many other team members. Dr. Spandana is there. So we have 3 teams, 3 vans every day. They go out, and so this is a continuum of care of these children in the home setting, and a very unique with children's hospice. We call it a Mandara hospice. Many of these children can't be managed in the home and they're very sick. So we move them to the hospice facility and provide the end-of-life care. And hospice is also a place where the family get a respite. So as you see, what happens there's a smooth continuum of care: hospital, hospice, home care. The child moves between all the 3 programs so that wherever they are, they get this care. Recently, again, 2019, Government of Telangana started a very unique program called District-Based Palliative Care Program, which comes under National Program for Palliative Care, actually. So every district, we have established a district-based program supported by home care. Now, what happens? Many of these children who come to Hyderabad, they are not from the district. They are not from Hyderabad. They are from the districts. Now, in these districts, we have these programs where we refer the children back. They are not pediatric program, but at least this is a general palliative care program. And we call 1-to-1 and hand over these children to these district programs. So they get some kind of continuation of care closest to their home, even in the most remote districts. So here you see a small baby. Parents died, grandmother looking after this baby because of HIV, and they're providing home care. One of our doctors visiting and providing home care in the districts, in a very remote tribal area. So if you see, like Dr. Marianne mentioned, the networking is an important part. Many organizations come together, The whole idea is how do we improve access to care? And this can be achieved only by nice networking of different organizations coming together. I stop here, and if there are some immediate questions we can take, otherwise we'll look at another very interesting aspect of palliative care, which I think most of you will relate because most of you are working in corporate hospitals. So very recently, Dr. Ishak started his program in corporate hospital. So I'm very curious to hear from Dr. Ishak about how he is convincing a corporate for-profit organization to do a pediatric palliative care. So I think we'll come back to questions combined together in the end.
Yeah.
Dr. Ishak.
Thank you. Am I audible?
Yes, you are.
Yeah. So, Vinila, can we have the slides?
Yeah. Just a second, sir.
So just to give a background, I've been working with Gayatri ma'am for the last 3.5 years, 4 years. Then I shifted to a corporate hospital. So the thing is, many a times people feel that, okay, palliative care is all about charity. It is something you do at the flag end of your career and all. But Dr. Marian and Dr. Gayatri have pioneered it, saying that it is not something you take up at the time of your retirement. It is something that is very much needed from the start. And many pediatricians and many physicians who might be your friends and all need to take this up because this is the need of the hour. So I'll just talk about few of the things which I used to convince my hospital here. The thing is, they approached me to start up a department, so it was a little bit easier. For you, it might be in a different way. For example, you might be pediatricians or neonatologists, or from other specialities, for example, a pediatric neurologist, who would want to apply few aspects of palliative care in your practice so that your patient gets an holistic care. There were multiple great points, practical points by uh, during the previous presentations where Dr. Marian talked about how to collaborate, how to bring in different stakeholders together so as to provide a continuum of care. Gayatri ma'am talked about how to bring in the government help so that the patients who might come from different parts of the city or the state, whenever they go back, they have some support. So I'll talk about a little bit about how we can convince our setups about why there is a need for a pediatric palliative care in the setting. Next slide. So again, whenever you speak to your corporate stakeholders or your heads, you need to tell them what is palliative care. You need to show what are the various components that we can bring. And like Gayatri ma'am has already told many a times, there are patients who abandon treatment because they're not well supported. That main aspect is something we need to bring. We need to talk about how we need to take care of caregivers' distress or talk to them about how to support them and how to bring them back to the hospital as well. So it is a teamwork all in all. Next slide. So this is something I wanted to share, that whenever a setup you want to start, suppose a palliative care setup, there might be people who deny it upfront, and there might be people who are phobic. There might be people who kind of love the idea that yes, okay, palliative care is something very important, but then again, nothing happens on the ground. So we need to bring them from the denial stage to palliative state, where something happens on the ground level. So they can see denial can happen from your hospital executive saying that, oh, how does it generate income? And by colleagues saying that we are doing everything already, we are supporting them. So when you're supporting them, still there is a gap. That is why we want to bring in a department where the gap can be filled. That's why you need to talk about also document what is the unmet need with the help of surveys, or you can simply show some testimonials of patients who have received palliative care from you and have told how important a palliative care team has been. Then if your staff is in the phase of palliphobia. So palliphobia is where they do recognize there's a problem, but then again, they start to question or get threatened by the new team. So we need to show them that We are not here to take away their patients. We are here to collaborate with them, try to greet them with a smile. Many a times that helps. Try to make friends. Try to have some mentors or supporters so that they can speak out about your work. And also, you can have some data of impact on your patients. For example, if you are coming from a setup where you have stayed in the hospital, you can show some data saying that these patients were having so and so symptoms during end of life. It would be helpful if we have a team that takes care of these kind of uh, life-threatening symptoms. Then you might also find people who are in love with the idea of having a palliative care department, but then again, there is not much things happening on the ground. So what you can do is, from these people, you can try to get some referrals. You can try to say that, okay, we want to train your staff, or you can use some of their data for research. All these things can be done. And at the end is palliative. So if your team heads or your corporate sector executives are in this phase, even if they are in Palilalia phase, it becomes much more easier to bring them to having something to do on the ground. So what does this involve? It involves providing of allocation of space, which Dr. Gayatri ma'am has told that you shouldn't try to take whatever space they give. Try to take a good space where there is a proper ventilation, where you are looked as a team, and it shouldn't be like, okay, there's some corner room given to you. Have formal curriculum space, have medical training program rotations as well, and try to inculcate the habit of training and research as much as possible. Next slide. So this is one more slide which talks about what are the various things we can do for our patients. We can do advanced care plan, end of life care plan. We can provide uh, means of taking care of caregivers. These things are mostly left out in all hospitals which don't have palliative care, for sure. We hardly give thought regarding, okay, caregivers need to be uh, given additional care because we are busy. But if we actually recognize the need, then only we can find ways of taking care of it. Next slide. So you have to tell your executives why there's a need for palliative care, because there are multiple areas that need to be taken care of. And what I've seen in Chennai, there are multiple private organizations which are providing rehabilitative care services, which are not very well trained. If you are in your setup, you can tell your executives regarding what all can be done, whether you can start a respite care unit. It could be a ward where a respite can be provided for the caregivers. A nurse can be put for the child exclusively so that she takes care of the child's need, and parents can get some respite away from being the main caregivers. You can talk about how palliative care can be a very good source of supportive care, not only for children as well as for families. You can talk about what are the various things during the end of life you can bring in. It could be by talking about uh, limiting unnecessary procedures or limiting unnecessary usage of life uh, prolonging procedures as well. And also, you can talk about hospice care, something that is not available. But then again, if you can collaborate with various organizations, it is something you can talk about. Rather than sending them home, we can send to hospice care and maybe have an MOU, etc. Next slide. And yes, it is for all chronic illnesses. It is not only for cancer. This is one thing we need to tell, because around 90% of children's palliative care consists of children with chronic illnesses. So when we tell this point, it becomes much more easier for them to accept that this branch is something that is needed. So after this course, you all will be generalist palliative care. So you can bring in the idea of having a small setup. It could start with small and slowly it can build up. At times, less is more. So at least even if you can play the idea in your private hospital settings that yes, we need a palliative care setting, it becomes easier. Next slide. So these are the levels of care, like I said. We as physicians, everyone need to have palliative care approach. After the completion of course, you're more of a generalist palliative care, where you can do short-term palliative care consults for isolated care needs. But then again, you need to collaborate with specialist palliative care physicians as well. So after this course, there are other courses also, which will make you specialist palliative care depending on your interests. Next slide. The reason to show the levels of care was all of you are now, after the completion of course and the assessment, a generalist palliative care person. So it becomes easier for you to pitch in the idea of a children's palliative care unit. So what are the benefits? Like already said, it improves the referral system from various centers because you in your center have a palliative care unit, and it also reinforces palliative care as a core component on a routine healthcare basis. Also, it has a very positive impact on the staff because they do feel that they have done better than what they were doing previously. Next slide. And these are the various services you can offer if you are setting up a CPC unit, Children's Palliative Care Unit. It could be an outpatient service. It could be a pain clinic where you specifically ask about children having pain or not. More appropriate in a cancer setting rather than a non-cancer setting. And you can get consults from other specialties of inpatient. It could be a child suffering from cystic fibrosis. It could be about how do you do an advanced care plan for a child with cystic fibrosis. It could be a child with uh, cardiac illness, cardiac heart disease, structural heart disease, where you're not in a position to operate, inoperable. So these are the various consults you can get when you have a unit. It could be acute palliative care, ER unit, emergency room, where they can come with serious symptoms where you can see them. They could be hospice, end of life services, admission for respite care, like I previously mentioned, and also about outreach to community. If your hospital has a setup, you can go to some distant places to do some camps and assess about the need. And also home-based palliative care is something you can offer. Next slide. So these are the minimum staffing that we need to have. And like I said, doctor is very much important in this setting. Nurses who are trained. What I want to tell you in this slide is you might not have all these people. For example, in my setup, I have psychologists, counselors, but they're not under me. But when you show that their need is more in your department, they might be more time allocated of theirs to you. And nurses, many a times you might not have dedicated nurses, try to train them. So whenever there is a consult, maybe you can use their services. And then pharmacists and social workers, again, depending on what you can have. Again, less is more many a times. Next slide. So these are the minimum training standards. Now, after completion of your 12 weeks course, you will be a generalist pediatric palliative care physicians. And these are the other things which you can take up. There are fellowship opportunities for doctors. And you can also suggest that there are different opportunities for nurses, community health workers, and volunteers. There is a website by name IAPC, in which you can clearly see all the various courses they provide. It is for a very basic pay. And these are the various centers that provide palliative care training, such as Pallium India in Kerala, IAPC. Then there is Hyderabad Center of Palliative Care, which is headed by Dr. Gayatri. Then there is Tata, Cipla. With Cipla, Dr. Marian is involved. Next slide. So this was the buy-in which I told for Apollo Hospitals, because it was one of the first corporate hospitals in India, and it's been there for last 40 years. So palliative care is something that is going to, or already has a boom currently, and your centers would want to be part of it by having a center of their own. So I told here, uh, the stakeholders here that we want to be in the forefront of healthcare in India. So this is something that we need, and it is the need of the hour. Next slide. And when you're in a huge corporate hospital, it actually helps that you have multiple people whom you can connect with and see that referrals flow, as well as you can also have different branches also. For example, the place where I work, there is an oncologist. There is a multi-specialty unit basically. So in your hospital, even if you might not have these people, it's okay. You as a person can form a team with other specialty or team members, such as nurses, uh, physiotherapists, social worker. You might not have all the components, but then again, we can start small and slowly grow big. Next slide. And this is one slide which Gayatri ma'am also posted about continuum of healthcare. We need to show how we are going to follow them up when they go home, so that there is a continuum and so that the patient comes back to us. So that is something an added buy-in for a corporate hospital. Next slide. So whenever we talk about starting a setup in corporate hospital, we need to see that the leadership has a vision about setting it up, or if they do have a vague vision, try to just formulate it and show that a palliative care unit is something that would be really helpful. When we talk about vision, there could be senior oncologists, there could be senior pediatricians, there could be senior other specialty members. Commitment of the institute is very important when we are trying to set up uh, a CPC center in a corporate hospital. We need to tell them that it is a value added service. Many a times it might not generate revenue immediately, but over a period of time, if you are involving different team members, also involving different components, for example, home care, respite care, hospice, etc., it will generate revenue. So, like I said, it is not, we don't want palliative care to be just like, okay, this is something of a charity. This is something that can also generate revenue. But then again, it is something that needs to be taken up by the hospital so that we can even explore those. And also about allotment of resources, unless and until we clearly state them, the need, we won't get the resources. For example, for me, I don't have a dedicated nurse, but then again, I have a dedicated psychologist and a social worker. As the numbers grow, then I will have a dedicated nurse. As the numbers grow, I can have a additional doctor, a post MBBS, or a pediatrician under me who will provide care for children. Next slide. So this is one of the strategies of WHO, where you can see the policy is something that covers both education implementation and the drug availability. Next slide. So whenever you're starting a CPC center, you need to think about how do you train and educate your staff. It could be your own staff, it could be staff that are already trained and they have come under you. It becomes much more easier. It is a luxury if you have. And always share experiences through your palliative care training and identify staff who are willing to work with you. It is never something that is forced. Never say that, okay, I want this person. It doesn't work that way. Try to find people who want to work with you and want to work in a palliative care setup. Next slide. Drug availability, like I said, there was one question in the chat as well, is very important. If you're in a cancer setup or in a setup where you see a lot of children with pain, availability of opioid becomes very important. Suppose if you're not having opioid availability, try to get it or try to find places where they can go and get those opioids. See that they store it well and also dispense it properly. And the hospital supply of pediatric formulations is important. In the previous place where I worked, there we had uh, nurses who would help us with pediatric formulations. For example, we had 10 mg tablet. If you wanted to give only 2 mg, we used to explain it to our staff and they used to take care of it. So always train them in that also. Next slide. And then comes policy and implementation. Whenever you're starting a setup, there needs to be a policy about why we need it. And under this, we need also commitment of the institute. If institute is not committed and they're like, okay, fine, we'll just give it a try, it won't help. You need to have a proper commitment, and slowly you need to pitch in the idea and bring them all in one stage. And it could be part of state and central insurance packages. Now in Ayushman Bharat also, palliative care is one of the package. You need to, this slide I have taken from my previous presentation. So you might require having a medical officer, having dedicated nurses. Also, you talk about training them by taking sessions. Next slide. And you talk about how do you network with various centers away from the hospital parent unit, and also talk about how to provide care when they go home with the help of an online setup. Next slide. So awareness and advocacy, you need to bring in different physicians from community as well as residents who are under you. You can pitch in the awareness of pediatric palliative care and why it is needed. Next slide. And one more important aspect of a program, if your program slowly builds up, you need to have a program coordinator. Back in Hyderabad, we had a Vinila to do this. It helps in smooth transition of patient from one service to another when you have a program coordinator. And also regarding procurement of medication, necessary equipment, etc. And also they work as a point person whenever you want people to connect to the organization. Next slide. So what is the buy-in? Next slide. So in every corporate setup or in a private hospital, we need to tell that this is something in the next couple of years or in the next decade, this is something that is going to have a huge boom. So if you're not bringing it in our hospital, some other hospital will bring it in, and the patients will slowly go to that place. That is something we need to tell, because that is what corporate hospitals work. And it is a value added service, and you need to show how you can generate revenue also. Next slide. The revenue generation could be through IP, OP services. It could be by referring them to other hospitals or taking care of them in a respite center, etc. Actually, in terms of budget, it is cost saving. Yes, it is cost saving. If your hospital is a very busy hospital and you're not able to admit patients on a chronic basis for children with chronic illness, you can provide care for them at home by providing some online consultations, sending a nurse, all this. Yes, it is definitely a cost saving. And staffing of palliative care, these are the uh, staffing we need to have. Bare minimum is something, at least you need a doctor who's trained in palliative care. You might have a nurse or not dedicated, but if you can have a social worker, it becomes much more easier because you want them to be in contact with the family as well as children as well. Next slide. And these are the other aspects you need to take into consideration once your unit increases. And also, if you're the only person who's taking care of children under your unit, it becomes difficult if you're not thinking about your own self-care. Think about ways of how you can kind of take care of yourself. Staff burnout will be there because of the emotional turmoil. It could be because of staff friction, attrition, etc. Few ways with which you can do some self-care is by meditation, yoga, working out, playing with children, etc. Next slide. And team meetings is something very important. So you can check in with your team members. It helps in decreasing the team attrition. If the head of the program, for example, you are heading the program, if you don't speak to your staff, they don't feel connected. Next slide. And try to foster relationships, try to get to know your patient better and their caregivers. Also, discuss your patients with the other specialties who have given you the referrals so that they know that you're trying to help and you're trying to provide the best possible care. That is how you will increase your referrals. That is how they will also feel that yes, palliative care is needed. And when the patient feedback also reaches them, then they do know that you are supporting them in a good way. Next slide. And research is also a very important part in your hospital if you're having enough caseload, or if you're having where you can have some case series, etc. Try to do that. Next slide. And collaborations is something which Marianne ma'am and Dr. Gayatri has told in detail. These are the various collaborations you can have. International collaborations works wonders. Suppose if you're going to start a program, please let us know. We'll try to bring in some international collaborators so that your organizers, so your executives understand that yes, this is something that is bringing value to the hospital. So try to collaborate as much as possible. Next slide. This is one of our team from Two Worlds Cancer Collaboration. And she is a nurse practitioner, Tamara. She's taking a workshop here. Next slide. And interaction with media. This is my last slide for the session. So once you have started CPC Center, try to interact with media. It could be a newspaper also. Try to just tell how you have supported a child, or also regarding your intentions of having a palliative care center. It could be advertisement. Because this can actually provide awareness to the families and they will come to you. Next slide. Next slide. Thank you. That was my session about it. And these are some training opportunities that you can avail. Since you have completed this 12 weeks course, we have an advanced certificate course that will be for again 12 weeks, which will include on-site training as well for 2 weeks. So these are the various fellowship programs. We have 1-year program in MNJ Cancer Institute, which is RCPCH accredited. We have one in Wadia Hospital. We have a couple of fellowship opportunities in Tata Memorial Hospital, Parel, Mumbai. One of it is a non-academic fellowship, and there is another fellowship which is a 2-year academic program. We need to keep in mind that these fellowships will also give you a stipend of 70,000-80,000 to 1 lakh, depending on the center you're working. So it is not something that is given for a very less amount of stipend. Next slide. And after completion of these fellowships, you are a specialist palliative care personnel. And we have some hybrid fellowship opportunities also. For example, a 1-year hybrid fellowship, and it is provided in collaboration with Hyderabad Center for Palliative Care and Two Worlds Cancer Collaboration Canada, where you need to have a 2 months of on-site training and rest of the 10 months off-site. It could be done from your centers wherever you're working. And the IAP certificate course, which you are part of right now, basic certificate course. And then people who have completed this course after assessment, you will be given an opportunity on priority basis for an advanced certificate course. So these are the things that we have. And thank you for your patient listening. I think there are some questions in the chat as well. So any questions regarding my topic or Gayatri ma'am's topic or Marianne ma'am's topic?
I just
Thank
point
you,
out
Vishnu.
that you do not have to work only in an institution. You can even work in private practice and still do pediatric palliative care. Even though it might be a little more difficult to set up in your little clinic over there.
There was a question about whether is there a scope for visiting and observing just for a few days in a pediatric palliative care center?
Yeah, so I think you put the answer there. No, let people say where they want to come, and I'm sure they'll get accommodated somewhere.
Yeah, I request like you just suppose you're visiting Mumbai or Hyderabad or Chennai, you have some places you can visit. You can just ask in WhatsApp. Otherwise, look for center nearer to your home. We can always help you. Put it in the request on the WhatsApp group.
Just one question, ma'am, Gayatri ma'am, you're talking about procuring opioids as an essential component of palliative care program. Ma'am, just a few words on that.
Yeah. So we all know that when you talk about opioids, especially oral morphine, when you talk about opioid medications like oral morphine, you need special license. It comes under NDPS Act. So you need that to apply for that license. There's a certain requirement. So I don't intend to describe the requirement here, but important thing to remember is that for that also you need minimum training, because when they look at we call it a recognized medical institution status. That's a license they give, and when they give that license, they look at who's on whose name are you going to procure opioids, who's a doctor who's capable of trained and capable of using judicious use of opioids in the center. For that also the training is important part. So anyone who's applying, please feel free to contact us. Any one of us. Dr. Marianne is one of the national level expert in helping you with that. Vinila is a real expert in this region, and all of us, we can help you. Just feel free to contact one-to-one with us, and we'll help you with the licensing process. But it's very important to plan. If you're planning palliative care, think about procuring that license.
But Gayatri, I just want to add here, I put it also on the chat that see, it's not mandatory. I'll tell you why. Places like Sion and KEM and even Nair Hospital, where our programs are going on, and even in the past, the Sion Hospital was the first program. They were very, very, very resistant. Means that is the management of the municipal hospitals. So we had no choice but to arrange through the distributors. I'm not saying you should not do it. Please don't misunderstand everybody on the group. Please don't think it does not need to be done. I'm just saying that there are alternative arrangements which one can make through distributors.
So what Marianne is trying to say is that suppose you don't have that support system to procure.
Your management doesn't support.
So all you can do is there are distributors. You can send the prescription with the patient, and they can directly get it from and most of the states they have it. Many states may not have it, but you can send the prescription. But it will be every time one-to-one. Like it's a lot of hassle for the patient to get it. Yeah, but that's another way.
But see, remember one thing: all of us who are doing non-cancer palliative care realize that the morphine is more required for cancer. Not so much for the non-cancer, except maybe in respiratory conditions. So the requirement in the non-cancer is not that high. I think we should stop and hand over to Dr. Fernandez because there isn't much time left for the end of this program.
I invite Dr. Armida Fernandez, ma'am, to
conclude. Good evening, everyone. It is indeed a pleasure. I joined the session, and to see over 90 people joining, it's such a huge sum. And I said, only pediatricians. I know I'm a pediatrician, but I know that whenever you have something like this, pediatricians come with a different heart. And therefore, when you talk of pain and palliative care, this is something that attracts pediatricians so they can reach out to the students. So hats off. I'm so happy to see so many people joining the session. Can you all hear me? The network is okay?
Yeah.
So to start with, I want to tell you that, you've done what is called the basic course in pediatric palliative care. And therefore you heard, Ishak beautifully describe how you can, ask for the services in a hospital, the staff you require. And yes, that's what you must aim at. But I want to tell you, each one of you, wherever you are, you could be in private practice, you could be in hospital practice, you might be seeing a patient in the OPD. Palliative care should be part of your practice. When you see a patient, you immediately start thinking, how can I relieve that pain, not only of the patient, but parents, when we have a child ill, it's the parents that suffer with them or their caregivers. And therefore, wherever you are, in whatever state, you can start palliative care services wherever you practice, even as an individual. And once you do that, then you slowly try and see, now you know how to do it, how to go about it. Then you can go to the institution where you're working, the hospital where you're working. It could be your own private hospital. Can you imagine your own hospital nursing that you have? You'll have added to it, you have a pain-free and a palliative care center. So this is something that would make people want to come because you're there for the suffering of those patients. So whatever you're practicing, you can really practice palliative care. So we are actually at the end last year of our session, but I've got very good news for you. Ishak already told you, we've asked IAP Pediatrics to allow us to have now an advanced palliative care course. And the difference is, whatever we've done in the basic course, it will be a more detailed, you'll have a better understanding of the subject in greater depth, and also added to the sessions like you have now online, you'll have to then have 2 week sessions in a center that practices palliative care wherever you all are. So we are looking at different centers across the country. It could be Mumbai, we know, we have already heard about Hyderabad.
Admita, we have lost you.
And ma'am,
Madam's
please
voice
put
is
on
not
your
heard.
video also. Shall I just ring her up?
You ring her up. Yeah, I think because she's gone off, I think.
Palliative care course. Huh?
Yeah, okay. Can you repeat that because we lost you for a bit?
Okay. Can you hear me now?
Yes.
Yeah. So at beginning of the year, you'll have an advanced course in palliative care, which will look at all the subjects more detail, and a 2 week in any institution that practices palliative care. And that would be just outpatient care, hospital care, and home-based care. So that's the plan. And we will let you know when it starts through the IAP. All those who have done the basic course, got through the basic course, then you can join the advanced palliative care course. So that's a good news. And at the end of the session, I want to thank everyone who's made this possible. And to start with, I want to thank our president, Dr. Upendra. I'm so proud. He's from Sion Hospital. Even when I started it, it was someone there as president of IAP. He allowed us to start and he encouraged us. He said, please, whatever you want in palliative care, let us know. Our incoming president, Dr. Baswaraju, he came for the inauguration, if some of you all remember. So I want to thank him also for being there and encouraging. So next year, we are going to have even more encouragement from IAP for the palliative care course. I want to thank our Dr. Rakesh Sharma, unfortunately, couldn't join us. He's the chairperson of the chapter on pediatric pain and palliative care. So I want to thank him as well for all the encouragement that he gives us for these courses. I want to thank especially the faculty. The faculty. If you know each one of the faculty are so busy. And I don't know if they found the come. So I really want to say a thank you to each member of the faculty. A big thank Gayatri. If it wasn't for your whole group and the services you offered, I don't think this would have been possible. And thank you so much, Gayatri, for and the way it has been conducted, the ease with which it has been conducted. Otherwise we could have a whole lot of problems. They've taken over the entire, the whole whatever we are doing at the course. So thank you, Gayatri, for so much for being there. Also to Vanilla, you heard Vanilla and also Swati, who have been the back support. We all have these sessions. We think everything is going smoothly, but the background work has been done by them. And I also want to say a big thank you to all the participants, in such numbers. I know you all have come in early, late, but we are saying for the advanced course, we must make sure that everybody join in on time. If you really want to learn and learn well, I think you need to be there on time, attend the session. And I've been a teacher for years, for decades. I like to look at the face of every participant. So when you all put it off, I don't know, are you having lunch? Have you gone for a walk? Are you sleeping? So you need to look at the eyes of everyone. And it's only that when they're listening, and there is mutually you're learning from each other. So Thank you everyone for joining the course, for being there. And let this message of palliative care, we should have started it long ago. We did in our own way, not knowing what it was called and how to do it in the correct manner. But each one of you who have attended the course, you are an ambassador for palliative care.
We lost Dr. Amita again.
We will have a degree in pediatric palliative care, hopefully in our country. So thanks once again, and hoping to see many of you all join us at the advanced course in palliative care. Thank you.
Thank you so much, Dr. Almira. Thank you so much, Dr. Marianne and Dr. Gayatri, Dr. Ishak, for this wonderful session that we have had. I hope everyone is feeling inspired to go and start palliative care, at whatever level that you can.
So is there a certification? How is it going to be, Savita? If you can explain to us.
Yes, if you have attended at least 10 out of the 12 sessions and you have done all your pre and post test, you will definitely be getting a certificate, a basic certificate in palliative care, pediatric palliative care. And Vinila will send it out in a couple of weeks. Vinila?
Yeah, so actually we have attendance for all the sessions, ma'am. So we are going to analyze that and look at the participants who have attended more than, as you mentioned by you, more than at least 10 sessions out of 12. We'll just have take little 2-3 days time in analyzing the attendance sheets, and we'll get back to you. I'll discuss with Dr. Shishma Malik, Dr. Gayatri, and also as well as look Dr. Armida Madam in, and then we'll see how to go about issuing the certificates.
Thank you.
Thank you.
Thank you. Thank you everyone for attending. Thank you.
Thank you.
Thank you, everyone.
Thank you all. Hope to see you for the advanced course.